Thanks for the organizing committee to invite me in this discussion. As we discussed, that this patient is having carcinoma colon. He is having a history of melena also, and he is having a tortuous vessel, which requires a skillful placement of the stent. And remember that if you put the wire, if you pre-dilate the lesion, and if you lose the wire and guiding access to the artery, it can be a havoc. So I will discuss about the thin strut jazz, which is most trackable and best stent for this setting. Why it is so? We all know that the ARC consensus on high bleeding risk features, which includes age factor, renal dysfunction, particularly the estimated GFR is less than 30, liver disease with portal hypertension, active cancer, anemia, if hemoglobin is less than 11. We often forget this thing that even hemoglobin is less than 11, it is major risk bleeding. Low platelet count, which is less than 1 lakh, particularly if it is less than 5, it is severe thrombocytopenia. From 50,000 to 1 lakh, it is moderate, and from 1 to 1.5, it is mild thrombocytopenia. So if it is moderate to severe thrombocytopenia is there, it is a bleeding risk for the patient. Stroke, ICH, brain heavy malformation, bleeding diathesis, prior history of bleeding or blood transfusion is there. These all are the features which categorize the patient for the HBR. OS is particularly important, and particularly in this setting, atrial fibrillation is very common because this group of the subset of the patients which require oral anticoagulation therapy in the form of means NOx can be there, or even simple like Astrom or warfarin can be there. NSAIDs and steroids, they are taken as a minor criteria, but OS is taken as a major criteria, right? And planned surgery on dual antiplatelet therapy, recent trauma or surgery, these all are the high bleeding risk criteria. We know that what is the actually we can see here, the blue part here is showing that these are the major criteria: OSC, low platelet count, bleeding diathesis, liver disease, and active cancer, and planned surgery, and so on. And the lower part, lighter part, which is suggesting that minor criteria, and dual features, which suggest that the binary features are there. So HBR patients are a large, growing, and complex population. We really don't know. If we analyze them, then we can really come across that up to 40% in different not studies means taken from the population of PCI group patients. Up to 40% of the PCI patients are at high bleeding risk. There is limited evidence in these patients. Complex anatomy is there, particularly like diabetic patients are there, CKD patients which have diffuse disease. They have 3 times greater risk of bleeding even for HBR patients on extended DAPT regime, and they have 4 times higher risk of mortality if they bleed post discharge. So actually the condition is critical, and in such patients, HBR patients, we should have a different strategy to protect them from the bleeding. At the same time, we should think about the ischemic part also, that they should not have the stent thrombosis. So optimal strategy to balance between the bleeding and the ischemic risk for HBR patient, we should try to find out. So this is my personal data on HBR patient in NH patient which underwent angioplasty. So we retrospectively analyzed 200 patients taken. Approximately we found that 32% of the patients were having the high bleeding risk. So that is a good number. As I told you, there should be a balance between the ischemic and the bleeding part, and optimal patient care and decision should be there. Few words on Resolute Onyx polymer. We can see here that because this is having BioLinks polymer specifically designed for the DRAS, it is having rapid endothelialization, minimal inflammation is there, it is having low risk of stent thrombosis, and it is having controlled revolution. So that's why it is a good stent choice for such patients who are having high bleeding risk. One independent study was performed which is showing that the proven healing at 1 month, where 15 patients were taken, and OCT studies were done, 3,600 stent struts were taken, and it was found that almost 90% of the stents were covered with the endothelium at the end of 1 month. So we know that if there is complete coverage of the stent, the chances of stent thrombosis in the later stage is less, and we can certainly reduce the dual antiplatelet to single antiplatelet therapy. It is having different design, which is having a single wire design. So because of that, the trackability of this stent is better. It can be tracked even in the tortuous vessels. Then second thing is biocompatible polymer is there, and both of these ultimately culminates into fast healing, which is, as I told you, in the OCT studies we have found. So here again, increased thromboresistance can reduce stent thrombosis risk, and it provides the option to discontinue the dual interplatelet therapy. We can see here the Resolute Onyx, which was compared with the Biofreedom in Onyx 1 trial, and it was found that this more fluorescent is better. So as compared, because Biofreedom is the only approved CE marked approved in high bleeding risk patients. That's why it was compared. The Resolute Onyx was head-to-head compared with the Biofreedom. It is not available in India, and it was found it was a non-inferiority trial, and it showed that the results were almost equal with the Resolute Onyx and the Biofreedom. And here we can say that the Resolute Onyx that showed superiority in thromboresistance also because of lower platelet aggregation can contribute to reduce stent thrombosis risk. Violin polymer trial with so-called novel technology, you can see here the synergy stent and the O0 stent. You can see that with O0, 86% lower ST rate was seen. With the synergy, there was like almost same, no significant difference was seen. Significantly lower spontaneous MI was seen with the Resolute Onyx stent here, you can see. And low stent thrombosis confirmed at 2 years follow-up. And if we analyze this thing, we can see here in the initial part, means acute, and the early stent thrombosis means within 1 month, we can see that the Resolute Onyx was even better numerically as compared to the Biofreedom.
Hello, hello, mic check, hello. Hello.
Here, that
hello,
one trial, Onyx 1 trial, this was first head-to-head comparison and with the Biofreedom stent, and almost 2,000 patients were taken in this study. It was a multinational, international study which included 84 global sites. It was single arm study actually. So it showed almost 1,000 patients were taken into both arms. And in the 2-year follow-up, almost 97-98% of the patients completed the study. In the study, was good part that average criteria for this HBR patients were taken as it was 1.6 average criteria per patient. 46% of the patient met 2 or more criteria for HBR. So different criteria like elderly patients, OAC, anemia, and all these things were taken into study. This part is important. This slide is important. Patient characteristics, almost 40% of the patients were taken as diabetic patients. Atrial fibrillation patients were almost 1/3 of the patients, because we know in such patient or in this group of the patients, anticoagulation therapy, OAC, is required, and this was a good number because OAC along with dual or single antiplatelet later on becomes important. Again, acute coronary syndrome was almost 50% in this study. So that is again important because we all know that the acute coronary syndrome patients are at high risk of stent thrombosis in the later stage. So we fear to stop, particularly as compared to the stable patients, where the stable angina patients undergo angioplasty, we don't fear so much. But if a patient who is having acute coronary syndrome, thrombus burden is there in such patients when we put stent, right? So we try to extend the dual antiplatelet therapy for a longer time. So in this study, almost 50% of the patients were acute coronary syndrome patients. If we go to the lesion and procedure characteristics, again, this study included almost 46 to 48% of the patients who are having moderate or severe calcification. And if we know that the calcification is an important part where the stent trackability becomes important, then even after putting the stent expansion becomes an important part. Then we can see here in this again that the crossover to other study stent was with Resolute Onyx, it was only 0.2%, but with the Biofreedom stent, it was approximately 4%, which was statistically significant. And because of that reason, the device success was also higher in the Resolute Onyx. So in this study, 92% of the patients were on dual antiplatelet therapy for 1 month, and later on they switched over to single antiplatelet therapy or OSC depending on. So here again we can see that the spontaneous lower MI was seen lesser with the resolute onyx as compared to the freedom biofreedom stent. Significantly lower CDTVR with resolute onyx was seen at 2 years. So this study, which was largest study and first study to compare DAS versus DAS. So it in further sub-analysis was done, and which included AF subgroup patients, complex PCI patients according to sex, diabetes, bifurcation, small vessel, ACS subgroup and imaging subgroups, and it was found that it was non-inferior as compared to the biofreedom. So resolute onyx was safe and effective in high bleeding risk patients on 1 month dual antiplatelet therapy, and if we see the MI part, spontaneous MI was even lesser as compared to the biofreedom stent. Short DAPT trial comparison, if we see here that the Onyx 1 trial were global trial and clear analysis trial in which patients were taken from the global analysis, US and Japanese patients were taken. So here again, it was like Onyx 1 was a randomized trial. And here we can say the different characteristics of the patients, that how complex lesion and the patient complexity was there. And in this trial, the important part was that patients were in the ACS group as well as highly calcified subgroup was also taken here in this patient group. We compare here like complex lesion were B2 and C, so 80% and 79% as compared to the other studies where it was less. Prior MI was higher and the ACS patients were higher in this study group. Broadest inclusion criteria was seen in this study group with the HBR patients. We can see here what is the ACR definition, and according to this, if we see the Onyx 1 global or clear analysis, which included almost all the criteria, and if we see the other leaders free and juice, it was taken with the bare metal stent actually. So comparison of bare metal stent with the drug-eluting stent. Master DPT, which was recently published, it included Ultimaster stent with 1 month and extended, means 3 months dual antiplatelet therapy. So it was like same stent with shorter duration or longer duration. So if we see this Onyx 1 global and clear, it included higher number of the patients which were having the these criteria. So largest data in highly complex HBR patient with resolute onyx is seen. Only DAS with head-to-head comparison versus DAS. 2 clinical trials with 2,500 highly complex HBR patients were included. Only DAS to show significant better results in safety outcomes. Only DAS to have 2 trials versus biodegradable polymer and 1 trial versus polymer. I'm not going into these parts. So if we say that it is the first and only DAS FDA, CE and DCJ approved for 1 month DAPT, and it is clearly written on statement updated in information for use, IFU. They have clearly written in their IFU that this stent is approved for 1 month. So in this case, I'm coming back to the first slide, means the case factors to be considered in this HBR patient who is a doctor who had carcinoma colon. He is having history of melena. So tortuous vessel, Shepard, crook, RCA is there. Then side branch SS is important because large RV branch was arising from the mid RCA, 95% lesion was there. And this was really HBR patients. We need a stent which can negotiate the tortuous vessel. We need a stent which is having the side means pore, or what we can say that opening, strut opening, which can provide a good access to the side branch easily. If we compare with the other stent, it is having a circular strut opening in resolute onyx as compared to quadrangular and different shapes in other stents. So this provide rapid access and easy access to the side branch also. And third thing is HBR patient. So data are with you that this patient, this stent can be used in such patients and can stop dual antiplatelet therapy. So choice is yours, but these are some of the data that we can use this patient in, particularly in this subset of the patients. Thank you, sir.
When you have a high bleeding risk patient, there's no doubt that the newer stents like Onyx, Giants, Energy are better. Well, I try to put my stent in the perspective. When you started doing angioplasty, it was believed that the mechanism of balloon angioplasty was compression of the biological tissue with exclusion of water out of the biological tissue, and it was followed by a drug-eluting balloon or drug-eluting stents. And with that, we have moved so much in the knowledge and the development of stent technology. So this was the horrible journey how we had with the Cypher stent because of thickness and the durable polymer. But every history can go back to the origin of the history, and we can always criticize on the hindsight. And these stents, horrible stents like Cypher or Traxxas, had very horrible polymer that was very thick and non-uniform. Now we have moved to a better polymer like your Onyx and Giants. We have also improved on the stent technology by putting a longitudinal stent where there is no hinge. When Pamaj and Richard was traveling in an aircraft, Richard asked the air hostess that how come these food trolleys are coming into line and without any like a rail, and there is zigzagging. The air hostess gave a simple answer that there is a hinge in between two food trolleys. That's how the Pamaj and Richard, they introduced the hinge, and with that hinge you can track these stents. Now after that, there are a lot of trackability problem has been solved with the Onyx design, start thickness. Now we are actually moving towards no hinge stent technology. I'll be highlighting those technologies where the polymer, the stent technology has improved so much that it can be placed even the distal, tortuous, Shepard, crook, RCA, left cornea artery within the brain. So we have started our journey with 140 horrible stent, 132 is a horrible Traxxas, disastrous stents we had, and then we have come down to 50. We had another disaster with 150 bioabsorbable absorb stent. Now we have 60 to 64, 65 is your biobind, 68 is a Vivo stent, polymer free stent, dual drug stent. We have 70 micron, 71 micron is dynamics, bioadapter, and my next speaker, Dr. Professor Gambhir, will be speaking on 73 abluminous stent. The start thickness is important, but it's not that important because the synergy or your Onyx or your Giants varieties, they have kept the 81 micron as the start thickness. Now, what do you top it up? You top it up with the polymer on the both sides, on the abluminum sides. The thickness of the polymer is also important. Now, you have the DPDS, durable polymer DS, on ultra thin start would have been the best. Unfortunately, none of them are having a less than 70 micron start thickness. Perhaps the polymer which are durable takes care of the start thickness which is more than 70 micron. Disadvantage of bioabsorbable polymer taken care of by thickness of the BPDS. So this is the transitions of first generation to second generation, third generation. So third generation starts with Synergy. This is the only bioabsorbable DS, and which has got very high radial strength. It can expand to a larger extent. It can be put into HBR risk. And then we had these bioabsorbable polymers in the host exam study. It has shown that there is no difference between biodegradable and bioabsorbable polymer. So all about giant stents, as I said, 81 micron, all about our DPDS, all Medtronic are DPDS, all Boston Promo series are DPDS, the durable polymer. The rest of the second generation stents are BPDS, including Boston Synergy. So these are the Indian stents doing very well, and these are the twilight stents. Many of these stents are not used in India. There are almost 30 stents. These are HBR patients. All are doing well. So stent is important. Start thickness is important, but not that important in today's perspective. I tell you why. So acute thrombogenicity, the gold standard was Giants. You see less stigmas, less stent on a Giants, whatever method you adopt, and it can be compared with Orsiro, Ultimaster, Onyx. So there is drug dilutions, drug elutions, drug release, or abluminum surface, whatever method we have done. Giants remain the gold standard. You have the least thrombogenicity with the Giant stent. Start thickness, as I mentioned, the fluoropassivation will remain there. Will be the next. We can improve upon fluoropassivation. For the time being, fluoropassivation is the gold standard. So drug elutions, what we have improved? You have improved the drug elution pattern, the drug dosage pattern. Like for example, Giant Sierra releases 1 microgram per millimeter square. The Chinese stent, Firehawk stent, is a very good stent for HBR patient. Martin Leon working on that. It is only 0.3, that too in the well. And 90% of the drug is released within 3 months. So after 3 months, you can safely, the Vivo ISR or the Firehawk, you can stop DAPT if the need arises. So abdominal concept was there to drug dosage reductions, but that is not enough. We found there's not much of big difference between the clinical outcome, POCO and DOCO, between BPDS and DPDS, as I mentioned. So what is important for the youngsters and the young fellows who are doing routine angioplasty, complex angioplasties, and this patient who is a doctor 50 years, HBR patient, if you are putting a stent or drug-eluting balloon, you have to give a minimum 1 month of DAPT. Drug-eluting balloon is safer options in these patients, but if you are contemplating to put a stent, please do use imaging, and imaging is the only answer to reduce the depth. It may not be the polymer itself, a drug or polymer free or luminous or luminous start thickness is important or not that important. So it can be, all the stents can be seen nicely with the OCT, and now we are moving towards the link-free DS, ultra-footprint DS, vasomotion DS without having a bioabsorbable scaffold, and bioreactive stent. So this is the INR stent which has been published in TCT 2022. There is no longitudinal link. It is glued or hold together by the polymer, so it can crack anywhere. And these polymers, can heal very fast with least inflammations on the vessels. And these are the stents where you have a very good optimal support, supreme flexibility, and allows vasomotions like your absorb or emirase, ultra low footprint with two markers, and it is porous. How low is a low enough dose to prevent ISR and promote faster healings? Now, if you look at the drug doses of Elunir, which was the first generation of this Iron Man, the Ionir is only 31 in comparison to Onyx and Giant. So drug delivery is throughout the envelope of these stents, not a patchy drug delivery. And it can be seen that in OCT they heal very fast. So this is again, this is a breakthrough technology. If you see on this side, there is vasomotions, and these are linked, and these glue are together for 6 months, and once the glue is absorbed, the polymer is absorbed, the hinges are free, they can move freely, and you get the vasomotions back. So dynamic stent has been promoted by Antonio Colombo in the EuroPCR last time, and these are another breakthrough where there will be no polymer after 6 months. The longer polymer you have to keep, because you have to keep these stents glued together for 6 months. So Vivo ISR is another breakthrough technology. You have a double drug, is a polymer free, and we have the longest data so far as far as safety, stent thrombosity, and your mesh with Vivo ISR stent. So long journey. Now coming back to your HBR, you have this patient definitely in HBR. If he has got colon cancer, your Firehawk, the POEM trial has included cancer patients like AIDS, OAC, CKD, liver disease, etc. There's so many factors has been included in many trials. So it's not possible to understand each and everything. So whatever you have seen in this patient, definitely this patient is a high-risk patient. I do not mind if somebody puts Onyx or Synergy, but Vivo ISR also can be put there. So polymer-free drug-eluting stent yesterday in TCT-MD, the ISR test 5 trial has shown that is non-inferior. There's not much of extra advantage of having. So what is important? The stent commandments, like if you have amazing, if you prepare the artery very nicely, taken the calcium by Rota, master of Rota is sitting, legendary Professor Gambhir is sitting, if you prepare the balloon, prepare the lesions nicely, most of the newer generation stent can go into HBR patients. Now, imaging, bed preparation, choosing your right stent is important. Now, the packaging is also important. So this is the man who is a doctor himself, and he was in the team of Bush. George Bush had the 90% LED stenosis. He was asymptomatic. He was doing daily jogging, etc. And he did his treadmill test, and then he said, you have to go for angioplasty. So he did go for angioplasty, and look at this gentleman who was actually giving a brief on George Bush, the president of the United States, on how the stents are put in human being. He doesn't know even how to open a stent. So knowing the package is very important. I mean, what size you are putting, what is the expansion, I mean, how much a 3.5 can be expanded up to 6 millimeter in a left vein. So distal diameter is important rather than polymer itself. That is my take home message here. So when I asked my chat GPT to write a poem on this man, the DS polymer, durable, bioabsorbable polymer, duration of DAPT, the bleeding ACS, a doctor, and RCA tortuosity, so my chat GPT wrote a poem for me. I got the latest tech that does the DS polymer, durable and bioabsorbable polymer, duration of DAPT, bleeding, I can control ACS, RCA tortuosity on a whole. The chorus says, I am a mission to make healthcare great. With my technological advances, I cannot wait. Using my knowledge and honing my skill to make sure healthcare here to stay and will. So that means artificial intelligence will be applicable for difficult cases, for simple cases, use your simple brain. And there is a lot of simplicity in current generation. Thank you very much for your kind attention.
He was not on the earth, but he was flying somewhere on the moon with some newer generation of stents, which I don't know whether they will come or not. But let me go on to straight away the subject. Well, we have a patient, the clinical profile is already with you. Let me just summarize for you the clinical features of the case. Because the primary objective of an interventional cardiologist in this case are three. A, how to approach this patient and get an acute result. He should be out of the lab with excellent angiographic and clinical result. That's the first primary objective of the angioplasty. Second objective is that his long-term results should be good. He is less likely, or he should not be a candidate to start with. He should not be a candidate who should come back to the restenosis because it's a challenging case. And the third point is, of course, the high bleeding risk. He is a case for high. He's got certain factors which make him a high bleeding risk case. So you have to take all those precautions which prevent bleeding during the case and also subsequently manages the antiplatelet regime in such a way that he does not land into massive bleeding because he is a malignancy patient. So for you to summarize the case, let's say that clinically he is a diabetic, which should be taken into point. He is having non-STEMI. His anatomy shows that he has got a culprit vessel which is RCA, which is called Shepard crook. Now mind you, this is the important point. Every Tom, Dick and Harry interventional cardiologist cannot go and do a Shepard crook, which is very tortuous. And lastly, the morphology of the lesion was that it is RCA 95% stenosis, which is long and ulcerated with a large RV branch. Well, with all these features, of course, it will be difficult or it was impossible for any one of us to get a case. But I'll show you a case almost akin to this. Besides this, he has certain high risk features or high risk for bleeding, comorbid conditions which you know, he had CA colon, history of chemotherapy and melena, and he was scheduled for GI surgery. Now, when I approach this kind of a case, the first thing is, as I told you, the success and safe procedure. And for success and safe procedure, you have to have an appropriate selection of the hardwares, including DES, and pre and peri procedural antiplatelet agent because he is a case for high bleeding risk. And then how do you manage this now, or how you do de-escalate his dual antiplatelet therapy so that he does not bleed subsequently. Now, this is just to show you that how I have chosen the Amplas guiding catheter for a graft. Now, coming to a case something like this, which is almost like this, but of course, I don't know whether they saw my case and put it into the clinical profile, but I don't think so. This patient, first thing is you have to select the ideal guiding catheter. It should not be Judkins, it should be Amplas guiding catheter 1 or a hockey stick. And you can see here, this is a Shepard crook, or it's a partial Shepard crook with a very tortuous artery, very highly calcified right from its proximal to the distal part, and there is a disease at the bifurcation extending into the PD. So almost like a RV branch. And guide wire should not be a routine guide wire, you have to pick up a hydrophilic guide wire. And stent should have all those features which I have enumerated in the last part. So what I picked up was abluminous drug-eluting stent plus, which, because this is a stent which is different from others. It has got a abluminal coating on a stent. And not only that, it has got a fusion coating, which is means the stent is coated, but besides the stent, the exposed parts of the balloons are also coated with sirolimus. So it is a DES, and in fact it is a DES plus drug coated balloon. There is also a edge coating 0.5 millimeter edge coating which is protruding outside the stent, and the purpose of this is to prevent edge restenosis. It has got a biodegradable film which, as Hazra has pointed out, doesn't make a difference whether it's a bioabsorbable or biodegradable polymer, and several studies are showing different results. And then of course the releasing pattern is very good. 50% drug is released in the first 7 days bus, and then the remaining 70% drug is released in the 48 days. And I'll show you in the last slide the histopathology from animal model. Now, so this stent has very highly flexible, it is conformable, remarkable side branch access. It has zero foreshortening and a good reduced strength, and the strut thickness is already told to is 71 microns. Now we have a clinical data to support what I'm saying. This is an enable registry, which is a post-marketing registry of abdominal DES plus, which was carried out in Gujarat by Dr. Samir Dani. And you can see here that's a very large number of patients, more than 4,000 patients, and followed more than 2,000 patients followed up for 1 year and then 2 years. And you can see that all across the board, whether it was MACE, cardiac death, TVR, and stent thrombosis, they were all very low. The cyan bars, they indicate at 1 year, and the orange color bar indicates the outcome at 2 years. So all they were very acceptable. And even in diabetic, like this patient was diabetic, so we picked up the diabetic data, and out of these 2,000 patients, 855 were diabetic, and there was a promising performance of this Abluminous Plus across all clinical endpoints, even in diabetics. And when they compared with non-diabetics, the data was as good in diabetics as in non-diabetics. Now this is my own experience. Of course, this is not been computed as yet. We are working on this. But this I want to show you the last, concentrate on the last column. Overall, this is a combination of Luminous plus nostrum stent, which is almost similar. All the other elution profile and stent platforms are same. So what I want to show is the success of implantation. Out of 113 Luminous, 112 we could negotiate the stent at the target site. So the success rate of implantation of stent was 99.3%. with Abluminous and 98.3% with nostrum. So with this background, let me take you to the case. So this is the case that we are talking about, almost similar case. Now we have to wire it with a hydrophilic wire, and after doing the wiring, the first thing was to prepare a bed for the stents to go, because we have to put stents right from the distal to the proximal part, and unless you prepare the bed nicely, unless you decalcify the vessel, these stents would be very difficult to negotiate down into the PT and PLV. So rotablation was done using 1.25 mm bar right from its proximal to the distal part. And having done that, we picked up a Abluminous long stent 3 into 40 on your left hand side. You can see that it could go easily right across the PD and into the PLV. So that was the first stent we deployed. Then we deployed the second stent, which was also 3.5 into 40 in the mid part of the RCA, went easily. And then the point to be highlighted here is that we deployed the third stent through the first two stents and went easily into the side branch, highlighting that a stent can easily access the side branch through the stent that has already been deployed into the main branch. So side branch access is very easy with this stent, and that too has been shown in a distal vessel. And then lastly, we deployed a long stent at the proximal part of the RCA, including the ostium, and the ostium, as we'll see here, is very widely open, indicating that this stent has got a high radial strength. So this is the kind of result which you can expect if you do scientifically step by step from rota to deployment of stent. So therefore the immediate results are excellent. So what we have seen in this case is that even a long Abluminous DES plus can be deployed successfully in a highly tortuous and calcified arteries like this, with a Shepard or a partial Shepard crook. It's possible to negotiate this stent into the side branch for distal bifurcation stenosis. Just one more slide, which is not the one. I'll show you another important feature as to how this stent can take the bends easily and can be. Now this is a left main bifurcation stenosis of moderate degree, and you see here that the circumflex 90-degree takeoff from the left main. And it's a very long lesion. It's not very easy to deploy a stent which is into a circumflex which is taking off at 90-degree, and that to a long stent. And see, this sirolimus eluting abluminous stent has gone easily into the side branch and then was deployed. So this stent has easily trackable and this is the final result into the left main. Now, second part of the problem in this patient is the high bleeding risk. Now, the features have once again been highlighted that this patient had CA colon, history of melena, and he was planned for GI surgery, and all this make him a case for high bleeding risk. Now, these are my thoughts on a patient who is classified as a case for high bleeding risk. How do you approach this kind of a patient to optimize the results of PCI? First thing is the appropriate selection of DS, which I have already told you that abluminous I thought was one of the best choices in this patient. Judicious use of pre-procedure antiplatelet therapy. So you have to possibly give a serious thought on the antiplatelet therapy in such a case. And then appropriate dosing of the drugs, anticoagulants during the PCI. Maybe you may have to cut down the dose of heparin, unlike the standard dose. And then de-escalate the dual antiplatelet therapy in high bleeding risk. I need not go on to my own stand and show you that like Resolute Onyx has a data of 1 year follow-up with 1 month of dual antiplatelet therapy and then followed up with a 1 month, with 11 months of single antiplatelet therapy. But now I'll show you, it is beyond doubt that almost with all stents, the dual antiplatelet therapy can be de-escalated after 1 month. So, pre-procedure in this patient, we give clopidogrel plus aspirin is a good combination and a loading dose of 300 milligram. One should avoid potent antiplatelet agents like ticagrelor and prasugrel because this patient had a bleeding, history of bleeding per rectum. And then thirdly, one has to do escalate of the DAPT after 1 month. Now, there are ways to do this. The first thing is for 1 month you have to give a short-term DAPT with potent P2Y12 inhibitors. There are several trials, several combinations which have been done, which I will not go into detail. One is aspirin. 1 month you give a DAPT, then after 1 month you give aspirin and decrease the potency of the DAP2. But again, it does not work because it leads to a high incidence of ischemic events. Other is you give only aspirin monotherapy. Although the bleeding risk events are reduced, but there is a higher incidence of ischemic events. Then the third strategy is you give only a clopidogrel therapy after 1 month of DAPT. This is okay, but not very high, a large volume of data is available. But possibly the best data is available from ticagrelor, which decreases the ischemic events after 1 month of single antiplatelet therapy. Ischemic events, there is no significant change, there is no significant increase, whereas the bleeding events are decreased. Now, lately, only the last month, there is a very interesting paper which has appeared in JACC, which is a P2Y12 inhibitor monotherapy versus dual antiplatelet therapy after complex percutaneous coronary intervention. And this is a meta-analysis of 5 studies. Where they have compared initial dual antiplatelet therapy followed by a monotherapy for 11 months versus dual antiplatelet therapy given throughout, both in complex PCI as well as in simple, non-complex or simple PCI. And they have given certain criteria for complex PCI which I am not going to do. Complex PCI constitute 20% of the cases and non-complex. Now this was the result. They looked at the primary efficacy endpoint of single antiplatelet therapy versus dual antiplatelet therapy, and the efficacy endpoint was in terms of all-cause mortality, MI and stroke, and they find that this was similar between monotherapy versus standard therapy. This is regardless of stent that you have used. So therefore, any stent that you use dual antiplatelet therapy for 1 month and followed up by a single antiplatelet therapy over the remaining period is as good as dual antiplatelet therapy. In terms of safety endpoint, they looked at the Bout type 3 or 5 bleeding and they said that there is a reduction in bleeding with monotherapy. So there is an advantage of giving monotherapy after 1 month. versus standard therapy, that is dual antiplatelet therapy in both groups being complex or non-complex. So this is just a histopathological slide with the luminous, which they have done a histopathology in a porcine model, and they said that there is a complete endothelization at 7 days, good inhibition of new intimal proliferation at 28 days with mild increase at 90 days, low injury score and absence of any thrombus or any. So a 1 month DAPT followed by 1 or 3 months of DAPT followed by 1 month of antiplatelet therapy is being planned, and I think the trial will start very shortly. So in end, I will say, friends, my strategy for management of this case would be drug luminous stent, like a luminous new generation stent with a stent strut thickness of 71 microns, which has got a drug both on the stent as well as on the balloon. And managing high bleeding risk, you have to avoid potent antiplatelet agents, and if you use a ticagrelor, go on to de-escalation to ticagrelor alone after 1 month of DAPT, and stop antiplatelets before surgery as defined in the literature: clopidogrel 3 days, ticagrelor 5 days, and placebo 7 days. Thank you very much.
The stage has been set by previous speakers, so I think the case has been elaborated, and my talk is going to be really, really short. So, stent selection bleeding risk case. This slide is very well known to all of us that high bleeding risk is defined as a BARC3 or 5 bleeding risk of more than equal to 4% at 1 year, or a risk of an intracranial hemorrhage of more than 1% at 1 year. So, this patient is definitely high bleeding risk because he is already having been operated for CA colon, and he is being scheduled for a non-deferrable surgery. So that adds to 2 components of high bleeding risk. And he is also at a high risk of thrombosis because he needs PCI to RCA for non-STEMI, and he is diabetic. So adding complexity, a young doctor by profession, Shepard crook RCA, ulcerated lesion, RV branch bifurcating. And we are not sure for our own population whether the so-called East Asian paradox, does it apply to our group of patients also or not? Meaning thereby low thromboembolic risk, but a relatively high bleeding risk. So what does an operator want? We want an acute success. We want easily deliverable hardware or stent, safety of choosing short DAPT therapy, and the data to support the decision. So among the ultra-thin stud stents, among the stents being studied for high bleeding risk patients, Synergy is the stent which is having the lowest thickness reported. The so-called ultra-thin stud stents yet do not have data as far as their safety in choosing this modality of short DAPT in high bleeding risk cases. And that's why I think, based on data, I think we need to discuss about Synergy. Does Synergy tick all the boxes? So as we know, it's a bioresorbable polymer everolimus eluting stent, thin stud, 74 to 81 micron, depending on the size selected, whether it is less than 2.5 millimeter stent or more than 4 millimeter stent. Platinum chromium metal alloy platform coated abluminally with an ultra-thin bioresorbable polymer. And these features were associated with a favorable vascular healing, low thrombogenicity, and it allows for a shorter DAPT action duration. As we know, a lot has been discussed about stud thickness also, but just to put up here as a comparative slide, that among the 3 stents, Synergy, Xience Alpine, and Resolute Onyx, the Synergy is having the smallest strut thickness compared to Xience Alpine and Resolute Onyx. As per the design, the strut thickness, peak radius, and connector angles, they were designed to improve the crimping profile and deliverability over the Promus stent. And additionally, this Synergy stent is equipped with 2 additional connectors on the proximal 2 segments, and that gives it increased axial strength. And this overall design then maintains its flexibility and conformability, which are very important as far as the anatomy that we are encountering, a Shepard crook RCA. So this is a comparative slide showing excellent conformability of Synergy in comparison to Xience Alpine and Resolute Onyx. Coming to the data, we have a senior study earlier reported with Synergy comparing with the bare metal stents in elderly patients. All of these patients were more than 75 years of age. Mind well, but currently, as far as this BRC criteria is concerned, they are forming into the minor criteria. They are not in the major criteria. And in these patients, DAPT duration was for 1 to 6 months, followed up to 1 year. And The results showed that BRC type 3 to 5 bleeding rate was 3% and probable or definite stent thrombosis rate of 1%. And synergy was proved superior as compared to bare metal in elderly that received a short duration of antiplatelet therapy. Next came the evolved short DAPT study, and here also there were high bleeding risk patients, but more importantly they had excluded MI and complex lesions and they were given 3 months DAPT. Rate of stent thrombosis and bleeding, they were also significantly low, relatively low, but probably because the overall patients were a low risk group as far as bleeding is concerned. But at least it established that they have favorable ischemic outcomes among this selected group of patients when treated with short duration of antiplatelet therapy. After these two studies came the POEM study, which was reported in 2021 EuroPCR. And the aim was to evaluate safety of synergy stent with, in patients with high bleeding risk with 1 month DAPT. And the study was powered for non-inferiority with respect to an objective performance criteria with a projected event rate of 9.4% at 1 year. And almost close to 440 patients, they were followed up and they were treated with 1 month DAPT and followed up for after 1 month, they were put on a single drug, which could be either one antiplatelet or even one oral anticoagulant without antiplatelet. The primary endpoint was death, MI, probable or definite stent thrombosis at 12 months. Importantly, this is a study which had included patients, almost 12% and 13% that you can see here on the slide, having cancer within previous 3 years, and those were planned for major surgery in next 1 year. So this is one important subset which was included in this study, which are relatively lacking in other studies. An average number of criteria of patients having bleeding risks, they were 1.7 plus minus 1. Diabetics were almost 38% and ACS patients were almost close to 34 plus 7. So that includes almost about 40% of patients were having acute coronary syndrome. So these data definitely helps us in choosing, making the right choice for the patient that we are discussing about. Sizable number of patients had complex lesions, stent diameters were about 24 millimeter. Importantly, imaging was used only in 3% of cases. So it reiterates the importance of imaging in optimizing your results before deciding the optimum duration of antiplatelet therapy. So the result was that the rates of death, MI and stent thrombosis were significantly low. And at the end of 1 year, the primary event rate was about 4.8%. Which was much lower than what had been estimated about. And you can see from this slide that after 1 month, only close to 59% of patients were on single antiplatelet, close to 30% were on oral anticoagulants. This is the slide which shows comparative data of several other studies which have been reported about the 1 month or shorter duration of antiplatelet therapy in patients with high bleeding risk. And all across, we can see the data with synergy stent, which shows relatively significantly low stent thrombosis rate and bleeding rate as well. So I think based on these parameters, it is safe to choose synergy as a stent because it is going to be giving that comfort of tracking the adverse anatomy that we are looking for, side branch access, and the data that we have as far as the safety of 1 month duration of antiplatelet therapy is concerned. I'll come to the last point about this, that stent failures are a reality. All of the studies are, what we are looking at is about 1 month and looking at 1 year, but what about the scenario beyond 1 year? Whatever we are trying to achieve is a safety for early survival and looking into even late survival also. And stent failures are a reality which all of us have witnessed. This one small image that I'm showing here is a 68-year-old male. Earlier, onyx was put in UK, that was 2.75 and 18 millimeter in proximal LAD, and he recently got admitted with anti-war MI. And what we find in the OCT study is that the almost initial half of the stent has been endothelialized, but the later half of the stent is completely denuded. It is not yet covered with endothelium. So this also happens. I mean, despite having all the data, you will come across some of these patients where the coverage with endothelium is not complete, it remains inadequate. Though the number may be small, but as the experience grows, we are going to encounter patients who are going to have late events as well. And that is not restricted to one stent, it can be with any other stent, it's possible. So what we are looking right now is the short-term data. We don't know about intermediate and long-term ones. We have had seen with stent failures with Zions also, short duration, long duration, possible. So, though it is said that more than 90% of stent is covered, but what about that 10%? And how are we weighing that safety of stopping the dual antiplatelet therapy in short term versus intermediate and long terms? So I think we are still in a zone which is gray. And yes, as a clinician, we need to navigate uncertainties. And at least based on the current data, it seems from the discussion that has been already done and what we are trying to understand here is that it's true that yes, any good, any current generation, third generation DS, if you are putting it optimally with bed preparation and wherever possible with imaging to optimize the results, you are still likely to get good results, and it may be safer to discontinue DAPT after 1 month with some caveats. So questions to be answered, as has been already been proposed earlier also with Dr. Hazra's talk and Dr. Gambhir's talk as well, that will coronary imaging have impact in further reducing stent failures in HBR patients while on single antiplatelet therapy? Because ultimately with innovation in products, you have reduced the that risk of adverse outcomes. It is your job to do your job optimally. And that short of imaging, I don't think we'll be able to do it in the right way. So under expansion, malapposition, age dissection, however good the stent is, probably if you end up with all this, you are going to end up with adverse outcomes. And in less than 1 month, your adversities mainly happen because of thrombosis. Beyond 1 month, your adversities are going to be with more of a bleeding issues. So I think it is essential to navigate that first month right, and thereafter probably you are able to sail through relatively easy if you have done the initial job right. And lastly, what about drug-eluting balloon, whether that can have a potential alternative option in hybriding risk cases? I think with these 2 questions, I end the talk here. Thank you for your patience.
So hopefully over the next 12 minutes, I'm going to persuade you that we have to go with data, and the only STEM platform that has this data specifically for this case is the Ultimaster platform. So really there are, it's a complex case, a 50-year-old man, diabetes, NSTEMI, ongoing pain, complex anatomy, who has colon cancer with a prior history of bleeding, and he's awaiting surgery. So I think there's 4 really key questions when trying to think about this debate, okay? It's a patient with colon cancer, ACS, complex PCI. So really the 4 questions we have to ask ourselves are, number 1, what is the risk of ischemic versus bleeding complications in this patient? Number 2, should we even be doing the PCR? Number 3, what platform should we be using? And number 4, the duration of DAPT. This patient needs surgery, so we would obviously want to have the duration of DAPT as short as possible, but is there data in this case to enable us to do that? And I'm going to go through each of these 4 questions. So the first question is, what is the risk of ischemic versus bleeding complications in this patient? Well, to answer this question, really the thickness of the struts, the polymer, the drug, the stent design will absolutely have no impact on bleeding risk, and it will have a very small impact in the shorter term on ischemic risk in this case. The key determinants of bleeding risk are colon cancer and prior bleeding, and for the ischemic risk of ACS, diabetes, the fact that he has complex lesion, but also the fact that he's HBR. These are the main factors that are going to determine your bleeding and ischemic risk. And as 2 of the prior speakers say, also how we undertake the procedure. So Dr. Hazra and Dr. Sheff both highlighted intravascular imaging. These are the factors that will determine ischemic risk. The rest of the factors on stent design are relatively irrelevant. So, in terms of bleeding versus ischemic risk, this patient has cancer. This is data from the Mayo Clinic 5-year follow-up data, and you can see that these patients with cancer, it's increased risk of both ischemic events, so increased risk of MI, stent thrombosis, but also bleeding events that you can see. In this patient, the patient's HBR, because he's got active cancer, he's waiting surgery, and he's had prior melena. So he's got 3 HBR criteria, very high risk of bleeding. What do we know about outcomes of patients with colon cancer? This is work from my group published in the European Heart Journal a couple of years ago, looking at close to 600,000 patients with cancer. So for colon cancer, in hospital, no increase in the risk of ischemic events. unless they have metastases, which this patient does not have. But in terms of bleeding events, very high risk, a threefold increase in the absence of metastases, close to fivefold increase in the presence of metastases. Going out to 90 days, ischemic versus bleeding events, you can see that colon cancer has 10% reinfarction rate at 90 days and around 4 to 5% readmission with major bleeding at 90 days. So, these are high-risk patients. So in this case, the 30-day risk of bleeding events and ischemic events is very high. The absolute risk of ischemic events is probably greater at 30 days, but the relative risk of bleeding events is largest. It's about 7-fold increase compared to non-cancer patients. So really, what we want to do is probably aim for shorter DAT. The next question is whether we should be intervening at all in this case, or whether we should manage medically. He's got active cancer, and then what platform, what duration of that? Well, I'm only going to show one slide here, and really this is the slide, again, my group has published, looking at outcomes in PCI, in STEMI, but same for NSTEMI. And in colon cancer, you can see in this figure that the event rates in medically managed patients is much, much higher than in PCI managed patients. So according to the latest cardio-oncology guidelines from the ESC, as long as the patient has a life expectancy over 6 months, which in this case he appears to do so, then we should be managing PCI. So absolutely manage with PCI with the sorts of techniques that Dr. Gambir very eloquently discussed in his case. So the learning questions, what platform, what duration of that? Now this is a key point of this debate. There are no head-to-head trials in cancer patients with ACS comparing stent thickness, polymer, stent design and outcomes, okay? Those are largely irrelevant. The question should be whether there is data showing efficacy and safety of short DAT in HBR patients, cancer patients, in high ischemic risk situations, such as ACS and complex PCI, compared to longer DAT. And everyone assumes that we should be doing short DAT in this case, but none of the previous 4 speakers have shown that it's safe to do so. They've not shown that you have better outcomes in this sort of case compared to long DAT, and that's the key question. And secondly, what platform? So we've seen some of these studies already. We've seen Biofreedom, we've seen Seniors, we've seen Onyx. And these studies do not help us in this case. They do not compare long versus short DAT. All they show us is what outcomes of one stent versus another at 30 days. They don't tell us whether we should be using 30 days DAT or longer term DAT. So the stents may be as good as each other at 30 days, or they may be as bad as each other at 30 days. What we need is good data to show that in such a case, with very high ischemic event rate, close to 10% at 90 days, that it is in fact better to go short rather than long. And only one platform has this, and that's the Ultimaster platform and the Master DAT data. So this is a randomized controlled trial comparing short DAT, so 30 days, versus longer DAT in high bleeding risk patients, which included cancer patients. And this are the main findings, showing similar MACE between the short and the standard DAT, but lower major bleeding. So the next question is, in this high ischemic case with an ACS, is it safe to go with shorter DAT? And the answer is yes. This is a subgroup analysis, the ACS subgroup analysis from the Master DAT trial, showing that there is no interaction by ACS. So in ACS patients with high bleeding risk, there's no excess ischemic risk if you go short DAT, but you still maintain the benefit of major bleeding reduction. Okay? The next part is there evidence that we can go short in the complex PCI group, subgroup? And again, this is the sub-analysis from the Master DAT trial. This is how they define complex PCI. Our case probably would fill this criteria because it's a long lesion, so you're probably going to need multiple stents, like in the case of Dr. Gambir. And again, this trial shows that in terms of ischemic complications, there's no difference between short and long in the complex or non-complex cases, but in terms of major bleeding, the benefit is the same, irrespective of whether it's complex or non-complex. So in summary, the main consideration, or one of the considerations, is whether we should do this case. Yes, absolutely. The second consideration is whether we can safely reduce DAPT, even though this is ACS and complex PCR and the patient needs surgery. The only platform that has this data is the Ultimaster platform. I've shown you this data. No other platform has that data. I think questions around strut thickness, stent design, polymer, absolutely relevant to this. The key thing that's going to impact on this patient's outcomes are whether we can reduce that short and whether the platform that we're using has data in complex PCR, in ACS, and HBR patients showing superiority of short-term versus long-term DAPT, and the only platform that has that data is the Ultimaster platform. I think what we've learned from this debate is, number one, imaging is key. I mean, Dr. Hazra showed great discussion around that. Dr. Chet, again, great discussion around that. I also think technique is key. Dr. Gambhir showed a great case. Technique is going to be important for the success of the procedure, and Dr. Gambhir showed, how to do this in terms of using good guide support, preparing your lesion with rotablation and so forth. But you can do that with any platform. So I rest my case and thank you for inviting me to contribute.